Without further delay, I'm very happy to introduce the next speaker because I know her very well because we basically work together and I transition my pediatric patients to her. So we move on basically from pediatric metabolic medicine to adult metabolic medicine. And the next speaker is Dr. Elaine Murphy, who is a physician in adult metabolic medicine. Dr. Murphy has qualified from Trinity College in Dublin. She trained in chemical pathology and metabolic medicine at the Imperial College NHS Trust and developed a specialist interest in inherited metabolic diseases. She has worked as a consultant at the Charles Dent Metabolic Unit, which is based at the National Hospital for Neurology and Neurosurgery in Queen's Square since 2008. And in general, it is a large metabolic unit for adult patients that manages almost like 2,000 patients with rare inherited disorders of metabolism, different categories, including as well patients with lysosomal storage disorders. Elaine, thank you very much for being here with us, and I welcome you, and yeah, the floor is yours.
Thank you very much, and to the organisers for inviting me today, and Johannes giving, as I knew he would, a very detailed introduction, so hopefully I won't have to explain too many things in my talk. Can you see my slides?
Yes.
Perfect. Okay, so there's my declarations. So, Spiro says, I work in the Charles Dent Metabolic Unit, and this is one of 5 adult inherited metabolic disease centres in England. We were established quite a long time ago, which has given us nearly 70 years now of being able to collect patients, essentially. So we have more than 1,900 patients. At the moment, we range from age 16 to age 87. So our eldest patient, aged 87, has CPT2 deficiency. And as you can see, we are right next door to Great Ormond Street Hospital, which has lots of advantages. We can easily do educational sessions together, we can transfer patients, and we can share a lot of laboratory and other facilities. So this
Elaine,
is yes.
just a comment, because we see your screen, but you are on like display setting. Can you go to display settings and swap to presenter view rather than?
I can.
Perfect.
How's that?
Good.
Okay,
Yeah.
sorry about that.
Thank you.
So I thought it would be useful to give you an idea of our numbers and the breakdown of the adults with urea cycle and the disorders in our unit. So we have 77 living active patients with a genetically confirmed urea cycle defect. As with most centres, I suspect all of you have more patients with OTC deficiency than any other condition. And as you can see, we have 3 times as many women as we do men. And the next most common disorder is arteinosuccinic aciduria with a total of 8 patients. But we have a good spread across all of the conditions. And just to drill down to that in a little bit more detail, to give you an idea of where our patients come from. So I've literally just looked back over the last 2 years, from 2022 to 2024. We've had 14 new patients come to us across those 2 years. You can see, again, varied conditions, but the majority with OTC deficiency. And of the 14 patients, exactly half, so 7 out of 14, were pediatric transfers. So patients with known urea cycle defects discovered either in the neonatal or childhood period and then transferred to us already with a diagnosis and on treatment. But what is often extremely surprising to both to pediatric colleagues, but certainly to general physicians in adult medicine, is that half of our patients actually come to us for the first time in adulthood. And just looking down through the list there, here's a man with CPS1 deficiency who was asymptomatic until his 70s, when he then presented with recurrent episodes of encephalopathy secondary to intercurrent infection. Here's a woman who was picked up with as an asymptomatic carrier of OTC following the diagnosis in her adult son, who presented for the first time in his early 20s. This is the sister of the same young man. She is also asymptomatic. And here we have a very sad case. This is a man in his 40s who was diagnosed following the death of his younger brother, but his brother was also in his early 40s, who had done an intense period of exercise, climbing 3 mountain peaks in the one day, became encephalopathic, and sadly died with a pneumonia only being measured shortly before death, and had severe cerebral edema. And then this case here is another quite sad case where an infant boy died with OTC deficiency, and then his mother was screened and found to be again an asymptomatic carrier. And here we have a young woman who presented for the first time following an appendicectomy with hyperammonemia and coma, and fortunately recovered completely. And some good news with this woman is that last week she had her first successful pregnancy. And here we have something that we're beginning to see a little bit more often, which is asymptomatic individuals having genetic testing, paying privately. In this case, this woman paid while she was pregnant, and again, another asymptomatic carrier of OTC deficiency. But it gives you the idea of the variability, the different possible ages of presentation, and the fact that even as an adult physician, you need to have hyperammonemia and genetic disorders of the urea cycle on your radar. So none of us need to be told that this is a metabolic medical emergency. Once we have a diagnosis in our adult patients, then very fortunately, we have far fewer metabolic decompensations than you might see in childhood. Adults have mostly gotten through the phase of their life where they're having recurrent infections. So on average, we would have one or fewer admissions per month in our population of 77 adults with the urea cycle defect. In the UK, patients are admitted to their local hospital, and in contrast to paediatric services, we would very rarely transfer our patients to our unit for care. There are a number of reasons for this. One is that all adult intensive care units are able to hemofilter, so you do not need to transfer for that. Two is that in those patients with known disorders, we give them a pack of their medications to keep. So we give them the intravenous nitrogen scavengers and an emergency guideline, and we introduce them to the physicians in their local hospital if at all possible, so that they can be started on treatment immediately when they present. Very occasionally we will transfer a patient, but it's usually not in the acute situation. It's usually when they've actually recovered and we want to work a little bit more with them regarding their diet or their oral medication. So that's probably slightly different from pediatric practice. Very sadly, first presentation with a family can still have a very high mortality. Um, Largely, this is due to reduced awareness of ammonia as a cause for encephalopathy in adult medicine, and there's far less training given to adult physicians about rare metabolic conditions than is given to pediatric physicians. And we also have the issue in that although we can filter in pretty much every adult intensive care centre, we do not have, most adult hospitals will not carry the relevant emergency medications. So if we don't filter immediately, we don't often have the option to start medications. The triggers for hyperammonemic decompensation in adulthood, many of them are exactly the same as in childhood, but we have a few special things. Um, Adults are a lot more likely to miss their medication, to be a little bit non-compliant, non-adherent, particularly if it's been a while since a decompensation. Um, the other thing that doesn't often happen in childhood is intense or unaccustomed exercise. A child will just stop if you try to make it do more exercise than it wants to do. Whereas adults often decide to do things like climb 3 mountain peaks or run marathons and just push through, and that can be a problem. The postpartum situation we'll discuss in a little bit more detail in a minute. And then deliberately having a higher protein intake. So young men in particular, very common, go to the gym, take protein supplements. And sadly, over the last few years in the UK, we have still seen deaths in young men doing this. It's really important if an adult turns up in an accident and emergency department, confused, irritable, aggressive, the first thought will always be alcohol and or drugs. And it's really important to not assume that all encephalopathic adults have taken alcohol or drugs, but also to recognize that excess alcohol, and in particular we found cocaine, can be a very strong trigger for an acute inherited metabolic disorder. So just because your drug screen is positive doesn't mean you couldn't have an underlying inherited inherited metabolic disorder. A lot of what we do is about educating hospitals. We're very fortunate in the UK to have a very well organised structure for inherited metabolic disorders. Many of you may have already seen the British Inherited Metabolic Disease Group website, and we have adult emergency guidance and paediatric emergency guidance there, which is fully available both to medical professionals but also to patients. The guidelines at the moment look like this. We've recognized that they're a little bit wordy, so our colleagues in accident and emergency have asked us to design an algorithm. These have all sort of that will fit on one page. These have all now been written, and we're just in the process of proofreading them and validating them, and then we will upload those onto our website. So that should happen shortly. The other thing that's important, we've talked about the various nitrogen scavengers and other medications that might be available, is if you are a specialist centre, if you are a university hospital, to talk to your pharmacist about what are the bare minimum emergency treatments that you should have on site and have quickly available. So this is what we have on our list, and depending on the type of patient that you have locally, you may have different drugs. And here are our drugs specifically for the urea cycle. And we also have the ability to very quickly then courier those 24 hours a day to another hospital that might not have them available. The patients are also told about the emergency guidance and given a copy specific to them. We would encourage our adult patients to wear a medic alert, so children will generally be with their parents or another carer who can advocate and speak for them. But if you have a somnolent or confused or an adult in a coma, it's very important that they have something on their person that indicates what their condition is. One of our patients, not with the urea cycle defects, but with PKU, took this to the extreme and has a nice tattoo letting everyone know that they have PKU, but not many patients will do that. There's also, again, on the internet, the European Reference Network and Meta Barn have worked together to produce this emergency letter template. Very useful if you're in clinic, you want to give a patient some quick, specific information, and you can all have a look at that website if you haven't seen it before. And then something that we think is very important is to assume that young adults and older adults will want to do all the same things in their life that all of the rest of us do. They will want to drink alcohol. They may want to do foreign travel. They may want to attend a big music festival. They may want to plan a pregnancy or not plan a pregnancy. They may need surgery for some unrelated issue. And to think ahead, so not only think ammonia, but also think ahead about what advice you would give patients in those situations. I've just shown you one of our booklets, but we have booklets for alcohol, for festivals. We're producing one at the moment for contraception. And it's really useful to be able to give patients this guidance and again, have them available on your website so they can be easily accessed. So I promised you some cases. So this is the first one. I've just got 3 cases and they just illustrate really the day-to-day life of an adult physician in inherited metabolic disease. So the first case is of a 28-year-old lady, not known to us, but she'd had 3 presentations to her local accident and emergency department over the period of about a week. She essentially had flu-like symptoms and a headache, and she'd known to have an ear infection, but she also had some associated abdominal pain. By the time she was brought back the 3rd time by her husband, who just wasn't happy that she wasn't getting better, she was a little bit sleepy. She was a bit confused. She was not verbalizing properly. So the neurologist was called to see her, and the neurologist thought that she might have encephalitis. He examined her. She had not had any seizures. She had no rash or neck stiffness, but she couldn't recall her arrival at the department and couldn't tell him what month it was. There was not a lot on examination, a bit of generalized hyperreflexia and some finger nose ataxia. It was a neurologist, so there was a battery of tests done. She had normal ECG, normal MRI brain, normal CT of chest, abdomen, pelvis, normal lumbar puncture, normal viral PCR, a lot of routine bloods. I've just put the liver function here, which was normal, impaired cognition, and an EEG that showed generalized encephalopathy, but no seizure activity. And as you can imagine, this was all done over a period of about 24 hours or so. So what's are differential. So as a metabolic physician, you look at things slightly differently. You think, well, what is the metabolic disorder? And essentially what you had were gastrointestinal symptoms, some confusion, and behavioral stroke psychiatric features. And the two favorite diagnoses here are an acute porphyria or a hyperammonemia. This neurologist had actually been to a talk very similar to this about 3 weeks before this woman presented. So as well as ordering all the fancy tests, he did actually do a urine PBG screen and requested a plasma ammonia. And this was very high at 293. So then you've got a neurologist who is not a specialist in inherited metabolic disorder, but has done the right test and then needs to think, right, what do I do next? So a few years ago now, together with Johannes and some other colleagues, we produced this guide. It's in practical neurology. It's quite useful still, I think, because it's directed at the non-specialists. So the title is there, Ammonia, What Adult Neurologists Need to Know. And what adult neurologists need to know first is that 90% of hyperammonemia in an adult is caused by liver disease. And you remember I said this lady had a normal CT scan of her abdomen and completely normal liver function. So they're happy if they see abnormal liver function because they'll immediately then get a gastroenterologist involved. But outside of that, they stay involved. And you can see the various different potential causes of this, among which is medications, which this lady was not on, bleeding, specific infections, etc. But down here we have, of course, the rare inherited metabolic disorders. And with an ammonia of 295 micromoles per liter and normal liver function and not on any medication, I would expect that that is what where the differential diagnosis would be going. Again, an amino acid profile was ordered. You're not going to get this back in accident and emergency for us. Even if we do it urgently, we're not likely to get it back within a couple of days. So you've got to deal with the ammonia without potentially knowing exactly what the genetic cause might be. But you see some very typical findings here. So we've got raised alanine and glutamine. We've got low essential amino acids, so either indicating, that fasting or hadn't eaten for a while, or maybe a more chronic low protein intake. And we've also got some of those amino acids that we've seen within the urea cycle itself low. Uh, it's a lot easier to see if your laboratory will kindly graph them like this for you. So you can see here, you can see how prominent the glutamine and the alanine are. So this is standard deviations from the population mean for these amino acids. And you can see how low the arginine and the citrulline are and some of the essential amino acids here. So a very nice pictorial representation of what is something quite challenging to look at in numbers, particularly for the non-expert. Also went on to have urine orotate measured, and we didn't really talk about that, but you can see here that if carbamyl phosphate increases, you can measure increased orotic acid in the urine. So what we've got here is we've got hyperammonemia, ammonia of 295, a low citrulline, a low arginine, and a raised urinary orotic acid. So quite straightforward then to make a likely diagnosis of ornithine transcarbamylase deficiency. And indeed, this young woman had a de novo OTC variant. And when we met her afterwards, when the neurologist referred her, she actually had a lifelong self-selected low-protein diet. She didn't like the smell or the taste of meat. She would rarely eat fish, very few dairy products, and basically survived on carbohydrate and vegetables. With this, she was a little underweight. And one of the things that people ask us is because actually she did not get any specific treatment at that time other than responding to antibiotics and getting some dextrose, but she did not, everything resolved very quickly, and she didn't at that time need any other immediate treatment, but was then referred to us as an outpatient. And what we often get asked is, well, when do you treat an adult? And it's a really difficult question. It's a bit like the question of when do you stop treating a neonate? So we have these broad guidelines, but what's really important is you need to review the patient very frequently. You need to repeat ammonia measurements, not just once a day, but maybe every 6 to 8 hours initially to see the direction in which things are going. also need your blood gas again to see the direction in which things are going, and really use your clinical judgment. So broadly speaking, we would say if there's any encephalopathy, you should be treating the patient. So ammonia above 100 with encephalopathy, think about treatment urgently. You then need to decide, is that filtration, oral scavengers or intravenous scavengers, but at least you're making a decision that you're going to do something. Um, if there isn't encephalopathy, you get all your diagnostic samples if it's the intake case, and you consider that you might need to start treatment quite quickly. So you're doing your regular review. If they're not encephalopathic and ammonia is less than 100, you've got a little bit more time. You may be able to watch and wait a little bit, but you still need to be thinking about, why is this going on? So initial management for this lady, we have our guidelines, we followed them. And we didn't, as I said, with this lady need to do very much. But actually, what you would be thinking is, because she had neurological compromise, you would be thinking hemofiltration, and all the other things that Johannes mentioned. So maintain anabolism acutely. We do that with some intravenous dextrose, limit protein intake. And again, I would stress what Johannes also mentioned, very rarely these days do we restrict dietary protein for more than 24 hours. Actually, even 48 hours for an adult is unusual for us. And for many of our known patients, we don't restrict it to 0. We just say not to have any high protein containing foods. So we might say, right, for the first day, no meat or no fish. But it's really important not to continue that protein restriction or no protein intake for days and days. You will just run into a vicious cycle and you will not get on top of the hyperammonemia. I now need to realize to change this from ammonia scavengers to nitrogen scavengers. So I'll do that the next time. Replace citrulline or arginine, replace other essential amino acids. And very importantly, many of our index case adults who have avoided protein, who have had a self-selected low protein diet, will be deficient in vitamins and minerals, particularly vitamin B12. And importantly, if you have a team, contact them for advice. Somebody asked a question about pregnancy. So this is a young woman. Her husband was bringing her in. They were planning a family. This is quite an old review now, but it's still very sobering and still worth looking at and still worth thinking about. And sadly, there are still some issues with pregnancy and the urea cycle defects. So this is a case series from 2010 of 7 women with OTC deficiency who had a pregnancy. The first 5 women, it was not known prior to their pregnancy that they had a urea cycle defect. And they either presented in the postpartum period with hyperammonemia or during pregnancy with vomiting. So what we would call morning sickness or nausea and vomiting of pregnancy and hyperammonemia. Sadly, the 3 women with the asterisks died either just after the diagnosis was made or before the diagnosis was made. But in contrast, these 2 women down here at the bottom, the diagnosis was known, they were managed in pregnancy, and they had a successful outcome. So what we think there are 2 risk periods in pregnancy. One is if you get severe nausea and vomiting, and that is not promptly managed, essentially you become catabolic, and that's a risk period for hyperammonemia. And the second is in the postpartum period, when the uterus, which is essentially a large muscle weighing about 900 grams, has to involute and be metabolized to get back to its pre-pregnancy size of about 56 grams. So that 2 to 3 week period following the birth of or the delivery of a baby is a risk period for hyperammonemia. Once you know, all of this could be managed. And then the specific question was, what proportion of women in pregnancy have high ammonia? In our experience, because protein tolerance increases as you go through pregnancy, as long as you don't get nausea and vomiting, in general, it is easier to manage a woman with a known urea cycle disorder in pregnancy than outside of pregnancy. So without nausea and vomiting, you will see the ammonia coming down and actually improving metabolic control. But then you mustn't get complacent. You must remember that postpartum, that could deteriorate again. So this young woman, her current management is an adequate protein diet. So we've worked with her on her dietary protein intake. She's on glycerol phenylbutyrate or Ravicti and L-arginine. She has subsequently had 2 successful pregnancies, which were managed with intravenous dextrose and ammonia scavengers during labor, and then careful monitoring postpartum with her oral scavengers being increased slightly. So my second case then I've called seizures. And this is a 22-year-old man who was admitted, again unknown to us, admitted to his local hospital with vomiting, confusion, agitation, and aggression over a period of about a week. On admission, he had a slight reduction in his Glasgow Coma Scale. It didn't look infective, and all his routine blood tests were normal. He'd never had a similar episode. No one else in the family was unwell. He did have a background of epilepsy. So he'd had head trauma aged 18. Remember, he's now 22. And he'd had his first fit following that and ongoing intermittent fits after that. He'd been tried on lamotrigine and levetiracetam, and for various reasons hadn't tolerated that. So in the preceding month, he'd been switched to sodium valproate, which had been increased up to 500 milligrams twice daily over a couple of weeks prior to this admission. And then with this admission, he'd come in with those findings. He was admitted, and the neurologists do know that that sodium valproate can cause hyperammonemia. So his ammonia was checked. It was higher than they were expecting. So it was running at 120 to 230 micromoles per liter on the ward, with a lower limit of 40, or an upper limit of 40, sorry, in our lab. And the neurologists decided to wean down the valproate and discontinue it. They did ask for an amino acid profile. And again, you see a little similar pattern than we saw with our previous lady, the elevated glutamine and alanine and the quite low citrulline. So this made them a little suspicious that there might be something else going on. And so they also asked for urine orotate, and that was also quite elevated. And again, just showing you how useful it is to look at these amino acids graphed. You can see how prominent the alanine and the glutamine is here. So he recovered without anything else other than the sodium valproate being weaned down, and was referred to our outpatient clinic. He gave a background history that eggs would always make him feel sick, and he also didn't like eating red meat. He was completely well now. He'd not had any further seizures. His ammonia was normal. Glutamine was now at the upper limit of normal, but within the normal reference range. So then the question is this sodium valproate-induced hyperammonemia, or is there something else going on? And the reason he was referred was because of how high the ammonia was. Because although sodium valproate is known to cause hyperammonemia, large studies have shown that this is nearly always less than 80 micromoles per litre. It does occur in a large proportion of patients, so some series say up to 80%, others a third of patients who are on sodium valproate. But the majority of people are asymptomatic, certainly not as symptomatic as our young patient was here, and certainly not over such a rapid time period. There is a higher risk if you give a higher dose of sodium valproate, and remember he was only on 500 milligrams twice daily, so that's not a huge dose, if it's combined with other antiepileptics and in older patients. So again, he didn't fit any of those criteria. The reason it causes hyperammonemia may be several factors. It is known to inhibit the first enzyme in the urea cycle, and it may also increase renal ammonia production. So because of this and everything not quite fitting, he was sent for further testing. And it turns out he did have a known late onset variant in the OTC gene. So effectively what we have here is valproate-induced hyperammonemia, but on the background of a late onset OTC gene variant. So valproate was the trigger in this case. And he's very well now, with no further admissions or episodes of symptomatic hyperammonemia. And this is quite some years later. We advised him to avoid a high protein diet. He's on arginine, but no nitrogen scavengers, and he has a copy of our emergency regimen. The final case then is to talk about a lady who is pregnant. So this is a 24-year-old lady who presented at 9 weeks into her second pregnancy. So she'd had a successful first pregnancy with a young daughter. She presented with mild nausea and anorexia just to the antenatal ward, and some intermittent vomiting for about 3 weeks. So very typical of just nausea and vomiting of early pregnancy. Her examination was completely normal. She was given an antiemetic and told to take folic acid, which she hadn't started, and to return in a week or earlier if her symptoms worsened. So there were no real concerns about her. She then presented to the emergency department 3 days later with severe anorexia, nausea, and vomiting. It was a national holiday in the UK, and because she'd been in a few days before, her medical notes were locked in a doctor's office and were not available. She told the team who saw her that in her previous pregnancy and in her childhood, she'd had some problems with low sugars. She had extremely difficult venous access and was admitted to the ward awaiting an anaesthetist to come and try and get an intravenous line to give her fluids. The next morning, this had happened and she had started on standard fluids, but she was still vomiting. Several hours later, she was getting worse. There was a suggestion that her blood glucose was dropping, but it wasn't anything very low, and she was becoming drowsy and not wanting to cooperate with her management. Several hours later, she significantly deteriorated and really was um, totally uncooperative and somnolent. Um, Very acidotic with a base excess of -26. Blood glucose still normal. She was, of course, at this point transferred to ITU. Acidotic. By the time she got from the ward to ITU, she had frank hypoglycemia and frank hyperammonemia with an ammonia of 195. Her medical notes were found, and it was realized that she had a childhood diagnosis of 3-hydroxy 3-methyl-glutaraldehyde lyase deficiency. Now, this is not a urea cycle defect. It is a disorder of ketogenesis, but we've already heard from Johannes about secondary inhibition of the urea cycle, and I wanted to include this case to show you what the real life presentations of hyperammonemia are for us. So we've already seen this, that you can have secondary inhibition of the urea cycle in a number of fatty acid oxidation disorders, organic acid or ureas, and in this case, a disorder of ketogenesis. But the really, really important factor, which I cannot emphasize enough, is that it is really, really unusual to see hyperammonemia in these disorders in an adult. And if an adult has hyperammonemia at all, even if it is not greater than 100, then it generally indicates that they are very unwell and you need to do something urgently. So you don't wait for it to go above 100 before treating. So this lady, once the diagnosis was realized, was started on appropriate treatment, dextrose, carnitine, her acidosis was managed, nutritional support was started, and she was immediately hemofiltered. Within 8 hours, there was an almost complete resolution of her biochemical parameters. So biochemically, she improved extremely rapidly with the appropriate treatment. However, very sadly, she had a spontaneous abortion several hours later. It then became clear that she had pulmonary edema, cerebral edema, and sepsis. So the whole process had rapidly deteriorated within a couple of days of presentation. And even though we were able to get on top of the biochemistry, she sadly died 18 days postpartum with multi-organ failure. So a very sad case. So to summarize, urea cycle defects are rare, but an eminently treatable cause of hyperammonemia in adults if you make the diagnosis, and the index case is the real challenge here. About 40 to 50% of cases referred to any large adult unit in the UK are new presentations. They are not transfers from paediatric services. So we still need to have a high index of suspicion of hyperammonemia in an adult patient. And we've discussed a couple of case examples of hyperammonemia triggered by infection, a change in medication, and pregnancy. And I will just leave you with some useful resources. And again, very happy to answer any questions.
Thank you very much, Elaine. That was a very good lecture. And it's always so fascinating to see the differences between, pediatric presentations and adult presentations. I'm also very skeptical, whenever I see, this percentage is so huge that almost half of your patients, are not basically transitioned from us, which makes me so skeptical about all those cases that might be missed, because when it comes to hyperammonemia in childhood, we need to think as well of very subtle kind of images, like children with chronic hyperammonemia can have failure to thrive or anorexia or mild global developmental delay with behavioral disturbances and headaches and things like that. So I'm really skeptical on whether we are just missing as well some cases, and they are not asymptomatic. It's just that there was a low threshold in pediatrician, finding those very subtle kind of manifestations and connecting them with high ammonia. Excellent. There is a question which says, is there a self-test for ammonia being considered for development? Like, for example, we measure blood glucose with diabetes or something like that.
Johannes is definitely going to be better at answering this one than me if he's still on. There is a self-test. I have to say we haven't really looked at it, and there are pros and cons. One is that you may make a decision to stay at home when you are actually unwell, just because your ammonia is normal, and not turn up in hospital. So that's an important caveat. So the short answer is yes, there are tests, and you can access tests. Whether it is something that we can see some value in it, potentially for some patients who are very far away from hospital. But at the end of the day, if you feel encephalopathic, or there's a change in behavior, or you're concerned about someone, it's not always your ammonia is the first thing. So you mustn't use this as a reassurance to stay at home. And we've already heard how ammonia as a chronic marker is not necessarily the ideal first-line marker. It's, again, a peripheral measurement. It's not telling us what's going on in the brain. It isn't a glutamine. It's very variable, so it will be higher after a meal, lower before a meal. You know, there's a lot of caveats to it. Of course, if you have an unwell person and your handheld device at home tells you that the ammonia is very high, maybe that would encourage you to go straight to hospital. But really, there are pros and cons.
Yeah, I completely agree with you, and especially with children's as well. It can cause so much parental anxiety, and then, you know, measuring unnecessarily ammonia to children can cause as well trauma. So I think that, again, I would be very, very skeptical about that. Excellent. Thank you very much,
Elaine. I would like to just comment on that, on the ammoniometer. I definitely would not recommend patient self-testing, because this testing has a number of pitfalls, and there are big inaccuracies. So it will cause also unnecessary worry or relief that nothing's wrong, because the test is not done properly.
We would have to assume that at some point there would be a very accurate test. And I think even with an accurate test, we would have some concerns. It might work well for some patients.
So I think that, do you have another comment?
Have we got time?
No, I think that we are over, actually.
Okay, then I just wanted to tell Elaine that she pointed out a lot of good points with the stock of the relevant medications. We've also had huge problems in the hospital, the need for special surgery protocols with the anesthesia, but you also gave us an idea about the booklet, which would be good to to organize a booklet for these patients. Thanks a lot for your input.
Thank you, Elaine.